Good afternoon, everyone. My name is Angel Maldonado. I'm the chair for the Emergency Medicine Critical Care Clinical Forum for FSHP. Our chapter is in the Southeast Broward chapter. I want to thank you for joining us for this forum meeting where we intended and are doing it with our colleagues in the Ambulatory Care Forum. So we want to thank you for joining. I hope you enjoy. We have excellent speakers. I want to thank Dr. Dewey Tran, Ivana Lugo, Dr. Marlene Mance, Dr. Lisa Kohler, very dedicated, well-tenured professionals here at Memorial focus on heart failure in our community. Did you guys want me to introduce you, or do you want to introduce yourselves? How do you want to do it?
We can introduce ourselves.
All right, take it away. Thank you so much, Lisa.
Yeah, no, thank you so much for this opportunity to speak today. Welcome, everybody. Thank you. So my name's Lisa Kohler, and I'm a clinical coordinator in the cardiology space here at Memorial Regional Hospital in Hollywood, Florida. So today we're going to begin our discussion by introducing some of the team of pharmacists who are going to lead us on a journey with a heart failure patient. With Dr. Dewey Tran, Ivana Lugo, and Marlene Mance, we're all going to review the impact of pharmacy on heart failure patients and their journey from the emergency room through ambulatory care. So just some common abbreviations that you're going to see used throughout the presentation are displayed here, and I'll just leave this up for a second. Okay. So the presentation objectives today for the pharmacists include a touch on the collaboration efforts on monitoring therapies, especially some of the novel ones in this space. And the pharmacist's role in terms of is emphasized throughout this presentation, particularly as it relates to medication selection, counseling points, all across the care continuum. And then the objectives for the technician audience members includes reviewing timely dispensing and emphasis on home medication review, as well as supporting medication access efforts, again, with some of those novel pharmacotherapy agents in heart failure management. So let's let the journey begin.
Hi, good afternoon or good evening, everyone. Thank you, Lisa. My name is Dewey Tran. I am the current PGY2 in cardiology at Memorial Regional Hospital. As Lisa mentioned, we'll be going through a patient's heart failure course from the ED to the ambulatory care space. And listed on the right, I have several services that are impacted by heart failure. So just a brief little snippet before we jump into the actual patient course. We can see that heart failure is a very systemic disease. We have several services. For example, nephrology might get involved due to like cardiorenal syndrome, neurology due to decreased brain perfusion, et cetera, et cetera. So not only are there multiple phases of care that the disease could be present in, there are multiple services that within each phase of care. That can you guys hear me?
Yep.
Oh, just making sure. Someone in the chat just sorry.
Yes.
There are so not only are there multiple phases of care, but there are multiple services that are impacted within each phase of care, showcasing how heart failure as a disease can impact not just the patient, but all of us as pharmacists in our respective specialties. But without that in mind, let's jump into our patient's journey. All right, so MT is the 57-year-old Hispanic male. And while I was working in the ED, I heard him complain about shortness of breath when he was talking to the nurses, talking to the doctors while I was on the unit. So he's complaining of shortness of breath. He reports that he's been having trouble getting up the stairs. And we know that heart failure patients often have these signs and symptoms, particularly that shortness of breath due to that decreased oxygen delivery to the body. The wife also reports that he's been having some swelling in the legs as of recent compared to previous days, and he's having some shortness of breath while mowing lawn, which directed him to go to the emergency room today. His past medical history includes hypertension and heart failure, and his family history is present with his father having hypertension. His mother's status is relatively unknown. He has an occasional alcohol drink for social events, and right on the right, you can see his reported medications. He's taking lisinopril 20 once a day, metoprolol tartrate 25 twice a day, spironolactone 25 once a day, and then furosemide once a day as needed. And we'll see what we can do to help optimize this patients as the patient course continues. Here are his vital signs, and you can see his vital signs are relatively normal except for his blood pressure. We have a heart rate of 81, oxygen saturation of 96, respiratory rate and temperature within normal limits, but his blood pressure is elevated at 145/100. On physical examination, he was found to have a lot of signs of fluid overload. We have that 2+ pitting edema, rales and auscultation, jugular vein distension, and he was reported to have a weight of around 173. He came in when we asked about his weight. He reported a weight of 173 pounds converted to kilograms of 78.6 kilograms. However, when we measured him in the ED, he actually had an actual weight of 84.2 kilograms. So all these signs and symptoms, all these examinations point to the patient having possible fluid exacerbation, fluid overload with his heart failure. Laboratory values, relatively normal, except for a couple. We have the serum creatinine a little elevated, hemoglobin's a little low, possibly due to the blood flow irregularities with the body and the kidneys. And also he has a BNP level of 1012, and that's kind of elevated. So we'll see to help optimize this patient to help normalize these lab values. Lastly, for diagnostic imaging, we have on the left the chest X-ray for the patient. It shows a lot of pleural effusion. You can see right here on the white kind of portion of the chest X-ray. And then on his echocardiogram, you can see an ejection fraction of 37% that was reported on the impression. So in summary, this is kind of a soap note kind of summary. The patient is a 57-year-old Hispanic male presenting with complaints of shortness of breath on exertion with a past medical history of hypertension and heart failure. He was found to be hypertensive with 2+ pitting edema, rales and auscultation, and jugular vein distension with pleural effusion and ejection fraction of 37%. So the ED team, assessed with all the signs and symptoms, with all the objective data, with all the subjective data, we assessed as a team that the patient was having heart failure exacerbation with fluid overload. And it was decided to give the patient 40 milligrams of furosemide IV, and then also give him an IV loop diuretic bolus challenge in our short stay unit with continuous volume monitoring. So what is a short stay unit? A short stay unit is kind of a middle ground between the ED workup and a full patient admission. It's not fully inpatient admission, but it's more intensive care per se than the ED workup. It allows providers to monitor patients a little bit more closely for around a few hours to days compared to traditional ED care without having to fully admit the patient inpatient unless necessary, of course. For heart failure patients, this is extremely, not essential, but really important because this allows the team to monitor weight, vitals, and volume status, as well as get more diagnostic exams or differentiation, and also evaluate short stay therapies like the IV loop diuretic bolus challenge. So for our short stay unit here at Memorial Regional Hospital, patients must be hemodynamically stable with signs of fluid overload. So kind of simple what our patients presenting with. Other notable exclusion criteria include severe hyponatremia, any signs of hyperperfusion such as altered mental status, any other unstable disease states such as acute coronary syndrome measured with EKG troponins, maybe sepsis as well. So our patients didn't have any of these exclusion criteria and was a good candidate for our short stay unit to monitor his heart failure status. So as an ED pharmacist, we have many responsibilities when it comes to managing heart failure exacerbations, but in general, we want to stratify causative risk factors, assess the appropriateness of diuretics, and monitor vitals, labs, and volume status. So for our patient, he did receive the initial 40 milligram IV bolus dose of Lasix, and it was followed quickly by, in the short stay unit, of an 80 milligram IV dose as part of our loop diuretic challenge, IV loop diuretic challenge. I wanted to first take a quick detour, however, and talk about some novel therapies that are implemented for heart failure currently, or some new novel therapies being implemented for heart failure. So on the left, we have Furoscix. This is a subcutaneous version of furosemide or formulation of furosemide, and it's been buffered to have a pH more equivalent to a normal body pH, so around 7.4. Dosing is given as a 30 milligram dose over 4 hours, initially followed by 12.5 milligrams each hour afterward for 4 hours. So over the 5-hour administration period, 80 milligrams of Furoscix is given, or furosemide is given, which is equivalent to 80 milligrams IV or 160 milligrams PO. This gives a lot of flexibility for patients that have these fluid exacerbations that require IV loop diuretics, but since it's subcutaneous, patients can actually be discharged on this medication without having to be admitted inpatient for IV loop diuretic therapy. Since it's relatively equivalent to the IV dosing and the pharmacokinetics are very similar in terms of the administration. On the right, we have Aquadex, and this is a form of aquapheresis. This is an ultrafiltration device, that is done to remove fluid from the body, similar to dialysis. However, one of the biggest benefits for aquapheresis is the minimal effect on blood pressure and on electrolytes, such as potassium and magnesium, that we see that are impacted a lot by our loop diuretics. So all in all, these two novel therapies show some promising and exciting innovations and advancements for our heart failure patients. So for our patient, of course, he had the furosemide 40 milligrams IV times 1, and then the short stay unit, he got the furosemide 80 milligrams IV times 1. We want to monitor our vital signs, so blood pressure, heart rate, O2 saturation, laboratory panels, especially our metabolic panels or magnesium lab add-ons, since it doesn't come with the BMP, calcium levels, et cetera, and also monitor the volume status with intake output, physical examination, and also urine output. So with the outcome of the short stay unit, the patient still remained fluid overloaded after IV loop diuretic bolus challenge, and our urine output that was saw was 350 milliliters. So the attending physician was notified with a plan to admit the patient to telemetry inpatient. So jumping into inpatient management, the patient was transferred to the short stay unit inpatient due to failed diuresis. And then we had the pharmacy technician and the pharmacist both conduct and review the medication reconciliation to help assess and optimize the regimens for the patient. So as an inpatient pharmacist working with the heart failure team, again, we have multiple responsibilities, but some of the main ones include conducting medication reconciliation, optimizing GDMT, and also educating the patient on GDMT and heart failure as a whole. Here is the fully reviewed medication reconciliation. And as you can see, there are a few things that weren't reported by the patient initially, namely the ibuprofen and the sodium bicarbonate or Alka-Seltzer for the heartburn. Now, these might have not seemed important for the patient at the time. Maybe he just gave a prescription list. He didn't really mention his over-the-counter medications. But doing a thorough review, doing a full interview for the patient, we see that he's taking some over-the-counter medications that could be exacerbating his heart failure. So we'll look to counsel that patient, the patient going forward along the course. For guideline-directed medical therapy, there are 4 main pillars for heart failure with reduced ejection fraction that all provide many benefits. This includes the right beta blocker, an ARNI, or angiotensin receptor neprilysin inhibitor, aldosterone antagonist, or a mineralocorticoid antagonist, pick which name you want to use, and then SGLT2 inhibitor. Our patient was on spironolactone, but is missing the other 3 medications. So taking a look at the current heart failure guidelines, patients with HFrEF or reduced ejection fraction should be on 1 of 3 beta blockers based on evidence from various clinical trials. And these trials include the CIBIS trials that were conducted for bisoprolol, the Copernicus trial that was conducted for carvedilol, and the MERIT-HF trial conducted for metoprolol succinate. These 3 trials and many others have shown these 3 beta blockers, specifically these 3 beta blockers, to provide both mortality and hospitalization benefits for our patients with heart failure with reduced ejection fraction. Similarly, the Paradigm HF trial, which saw sacubitril valsartan compared to nalopril, this established the uses of ARNIs to also reduce morbidity and mortality in heart failure patients with reduced ejection fraction. And with the rise of SGLT2s, the DAPA-HF trial and the EPIN-reduced trials have shown cardiovascular benefits from specifically 2 SGLT2s, dapagliflozin and empagliflozin. These 2 agents have shown cardiovascular benefits, and namely dapagliflozin, because the data was a little bit better in the DAPA-HF trial compared to empagliflozin in the EMPA-reduced trial. But with these 2 agents, they have been firmly established in the new updated 2022 guidelines as a 1A recommendation to provide both mortality benefit and morbidity benefits, regardless of diabetes in heart failure with reduced ejection fraction. So going over some additional evidence and literature, this was a cross-trial analysis that was done to compare conventional therapy that includes either an ACE inhibitor or an ARB plus a beta blocker to comprehensive therapy, which includes all four pillars: our ARNIs, our beta blocker, our MRA, and our SGLT2. And you can see with the data here, it shows significant mortality benefit mortality reduction, benefit reduction when comparing to comprehensive therapy to conventional therapy. You can see on the left graph, this is the graph of event-free survival from age 55 to 90, and the right graph shows event-free survival from ages 65 and 90. You can see on the left side of the graph, the 55 to 90, we had an increase mean survival improvement around 8.3 years on average using comprehensive therapy. And even at age 65 to 90, it was around a 6.3-year increase when using comprehensive therapy compared to conventional therapy. And then turning the page, this is overall survival, similar data, but this is with events, but overall survival. And you can see with the same concept, comprehensive therapy still outshines the conventional therapy. 6.3 years gathered increased when using comprehensive therapy compared to conventional therapy from ages 55 to 90. Then 65 to 90, we had an increase of 4.4 years. So all this data, all this evidence kind of shows that we can improve patients' quality of life, improve mortality benefit by just picking the right agents, using evidence-based medicine with GDMT, and help optimizing the patient's regimen accordingly. So with all that evidence in mind, all the data we kind of talked about, here are the recommendations that we made to the heart failure team as the inpatient pharmacist to optimize the patient's GDMT, as well as optimize the volume status for the patient. So with those recommendations, these are the heart failure team's interventions. So we discontinued lisinopril, provided a 36-hour washout, and then initiated sacubitril valsartan. We then changed metoprolol tartrate to the right formulation, metoprolol succinate, and also initiate dapagliflozin. For his fluid status, an IV loop diuretic infusion was started after the failed IV loop diuretic bolus challenge. And then once euvolemic, the plan they initiated the furosemide 40 milligrams IV times 3 times a day after discontinuation of the IV infusion. So inpatient outcomes, our inpatient team continued to run with the pharmacist on the patient daily. After a few days, the patient's symptoms began to resolve with medication optimization, GDMT, loop diuretic optimization, and then attending physician was notified that the patient was cleared for discharge accordingly. And for his GDMT, he is now on all four pillars to provide the maximum benefits to treat his heart failure. We have the right beta blocker, metoprolol succinate. We have the sacubitril valsartan. We have the MRA, spironolactone, that he was already taking. And now we have additionally the SGLT2 and dapagliflozin. And now I'll transition to Dr. Mans for the transitional care portion.
Good afternoon, everyone. I am Dr. Marlene Mance. I am a clinical coordinator here at Memorial Regional, and I spend some of my time staffing in our outpatient heart failure clinic. I'm going to discuss the roles of the transition of care pharmacist in our scenario with our patient. So our patient has been stabilized, and initial guideline-directed medication therapy has been optimized. So the role of the transitions of care pharmacists are to identify any medication barriers that might exist, initiate referral to our pharmacy medication access team, and also to provide discharge counseling for our patients. And keep in mind that the transitions of care pharmacist is made aware of the patient prior to discharge so that we can start working through any medication barriers that might arise and make sure that our patient has access to medications, the prescribed medications upon discharge. So our first step is to initiate a referral to our medication access team. So here, what you see is an actual visual of the template that we use. It is a standardized template to communicate to the medication access team that we are going to need a benefits investigation. So for this particular patient, this is, of course, going to be the template for our heart failure medications. And in our patient, we need benefits investigations initiated for the sacubitril valsartan and for the dapagliflozin. Just want to give a little background regarding the difference between a benefits investigation and a prior authorization. So what we initiate for our medications that may have any barriers is a benefits investigation. This is basically a query into the patient's insurance coverage to see if the medication is going to be covered fully, partially, or maybe not at all. If the medication might be partially covered, the benefits investigation is also where we find out if the patient has any co-insurances, deductibles, or anything of that nature that is going to affect the patient's out-of-pocket cost. We can also find out through the benefits investigation whether the patient's insurance company has, say, maybe like a tiered formulary where they require step therapy and they want the patient to try an agent that's on their formulary prior to allowing the patient to move on to a newer or novel medication. And another important element of the benefits investigation is to find out whether or not the medication is restricted to any type of specific pharmacy for dispensing. In contrast, the prior authorization is your process to obtain approval from the plan before prescribing the medication for the patient. So this is where we have to justify the need for the medication and basically explain why, although it's not the most cost-effective option, why it is the best option for our patient. So I discussed our sending the referral to our medication access specialist. I just wanted to show on this particular slide, and this is coming directly from FSHP, just to show the importance of the medication access specialist. So this is actually a position that is endorsed by FSHP, and it is an advanced pharmacy technician role. These pharmacy technicians are very knowledgeable. I mean, their knowledge is invaluable regarding different insurance plans, insurance coverages, knowing where to go to find resources for the patients to help them make their medications more affordable, et cetera. So again, I just wanted to add this slide just to show that FSHP really endorses this specific position for an advanced pharmacy technician role to assist and advocate for patients in being able to obtain their needed medications. Okay, so at Memorial Regional, our medication access specialists, in addition to benefits investigations, prior authorizations, they assist with co-pays. Basically, they help patients find any patient assistance programs that might be available. If the medication is a REMS medication, we assist with filling out the forms, making sure that the proper labs, tests, et cetera, are ordered so that the patient can be enrolled in the REMS program. And another invaluable service that our medication access specialists provide is that they are able to run test claims. So we are able to see right away what will be the cost of the medication to the patient. And we communicate with the patient so that we can determine if this medication is going to be a viable alternative for the patient. The loop with the arrows, I just wanted to point out that our medication access team consists of our medication access specialists. It says RSP because we also interchangeably refer to them as our reimbursement specialists, the physicians, the pharmacists. So if there is a consistent cycle of communication in making sure that we get the medication for the patient if we are able to. So a lot of times the medication access specialist will need further in-depth clinical information, and they will ask for assistance from the pharmacist with obtaining that information. Sometimes we have to go back to the physician and tell them, you need to beef up your documentation a little because, what you have here is not specifically what the insurance company is looking for. So it is a continuous cycle. Our medication access specialists document in the progress note in the patient's chart every step of the way. So we don't have to call them. We can look in the patient's chart, look in the note, and we can see where we are in the process. And that is ultra important because a lot of our patients, they're anxious. They want to know where we are in the process. They need this medication, and we can go right in their chart and say, we spoke with the insurance company, we're at this step. They said it's going to be, another 72 hours for determination. So it is just a really awesome service. Unfortunately, there are going to be times where we've done our due diligence, we've even, submitted appeals, and there's just a barrier that we cannot resolve. And in that case, we go back to the prescriber and we discuss alternatives. So although it might not be the optimal medication that the prescriber desired initially, we still are making sure that our patients are getting much needed medications. So for our particular patient, the medications with barriers are the SGLT2 inhibitor. Our prescriber preferred the dapagliflozin. Dapagliflozin. However, what we see in reality in our practice is that insurance companies are going to prefer one or the other on their formulary, and that drives the final prescribing decision. So that's not something that we usually, go back and forth and try to appeal, as Dr. Tran said earlier, that the dapagliflozin, the outcomes were a little better in clinical trials. However, both dapagliflozin and empagliflozin are both approved for heart failure. So whichever one the insurance company is willing to cover, that is the one that our prescribers will go with. As far as the ARNI, the sacubitril valsartan, what we usually see now is that many plans do not require a prior authorization. Once the heart failure guidelines were updated with such strong evidence for recommending the sacubitril valsartan, a lot of the insurance companies dropped their requirement for a prior authorization. However, you do have some plans that still require a prior authorization. And one thing that they're definitely going to ask for in the criteria is that the patient has an ejection fraction less than 40%. Other areas where we're able to assist outside of a prior authorization with the ARNI is access to manufacturer copay cards for commercially insured patients. The manufacturer also has a patient assistance program that provides free drug for insured and uninsured patients. The patients are assisted with this paperwork. For the patient assistance program, there's usually an income restriction. So we assist them with all of that paperwork. They usually have to show, tax returns, et cetera, to show that they cannot afford the medication. And also we assist with foundation assistance. A lot of the pharmaceutical manufacturers have grants that are available. And if patients are eligible, they can receive free drug. So again, our medication access specialists are so well versed in all of these areas, and it really helps to have them on board. So say, for example, you might be excited because you see a, copay card that is available for a patient, but our specialists know to be very careful with that, because you don't want to give a patient the initial copay card they're able to afford. They're able to receive the first 30 days of the ARNI, and then they're not covered for anything after that. So we look at the entire picture to minimize as many barriers as possible. So some of the advantages, of course, and I've mentioned a lot, but just overall advantages of the benefit investigation and the prior authorization prior to discharge when possible is improved medication adherence. And as pharmacists, we all know the benefits of improved medication adherence. So when we're able to perform all of these functions, keep the patient involved, and keep the patient informed prior to discharge, the patient knows what are the cost expectations. And that helps to reduce delays in care, because the prior authorizations have already, or benefits investigations have already been performed prior to discharge. It reduces abandoned care. We don't have patients arriving at their outpatient pharmacy and, getting shocked with a high copay and just neglecting to pick up the medication, just leaving it there. And of course, improved medication adherence potentially leads to a reduction in readmissions. We do have several outpatient pharmacy locations within the Memorial Healthcare System. We try to drive our patients toward our outpatient pharmacy locations. And the reason is that once our medication access specialists have started working on benefits investigations, prior authorizations, we have a record of everything that has been done to obtain medications for the patient. And it's easier within our system just to be able to further assist patients, because we know the past history, we know what their plan covers, does not cover. So it really helps to keep everything under one umbrella so that we don't have to, try to piece together information. So as I said before, one of the responsibilities of the transitions of care pharmacists is the discharge medication reconciliation and the discharge medication counseling for the patient. So for our particular patient, we would review each medication, of course, going over indication, dose, frequency, time of day, some potential side effects that they might look out for. So in this case, we would make sure to let the patient know that the lisinopril has been replaced with the sacubitril valsartan, and that the lisinopril should be discarded. They should definitely not be on both of these medications. So if they have any lisinopril that is still at home, they can discard it and take it to their physician's office, whatever they decide to do, but that they definitely should not be on both of these medications. Also, one thing that I like to explain to patients who are starting sacubitril valsartan is that it is a drug that we try to titrate to a certain dose. And in this case, our patient is starting out on the initial dose. So I let them know that, if possible, there will be an escalation in the dose of the medication depending on how they tolerate it. For the metoprolol, I would explain to the patient that the formulation that they were taking at home is not the formulation that is recommended for heart failure. Same medication, but different formulation, and that they would actually be receiving the same daily dose. However, they would only be taking the metoprolol once a day now instead of twice a day. For the spironolactone, there were no changes. It is still 25 milligrams daily. For the furosemide, this is a major change for the patient. Before, it was prescribed only as needed, and now it is a scheduled medication that our patient will be taking twice a day. Here, I would emphasize that the second dose should be taken no later than maybe 5 or 6 p.m. because we don't want the patient to be back and forth at night going to the bathroom, and that way we can minimize the chance of falls. For the dapagliflozin, I would explain to our patient that this is a new medication and that it has been shown to have benefits in patients who have heart failure, regardless if they have diabetes or not. A lot of our patients, they've done their homework, or either a family member has done the homework for them, and they come back and say, oh, this is a medication for diabetes and I don't have diabetes. So that is something that I like to stress there. As far as the over-the-counter medications that the patient was taking at home, the multivitamin is going to be continued. However, we have to explain that the ibuprofen that was being taken as needed for headache and the Alka-Seltzer as needed for heartburn are considered to be high-risk over-the-counter medications for heart failure patients. So for the ibuprofen, I would explain that it can potentially damage the kidneys and worsen heart failure. Therefore, acetaminophen would be recommended for any headaches. And also for the Alka-Seltzer, I would explain that the high sodium content can worsen heart failure, and an alternative would be, for example, calcium carbonate or brand name Tums. For our heart failure patients, our non-pharmacological counseling is right up there with our pharmacological counseling, because these patients need to know how to self-monitor. They need to be aware of the changes that they're going to have to make in their daily lives, in their diets. So for example, weighing themselves daily, going over foods and the sodium content in some foods, and helping patients, maybe providing a list of foods that have a lower sodium content. Depending on the instructions that were given by the physician, we'll discuss the amount of fluid intake, and to not, have fluid overload by ingesting too many fluids. And also we will talk about physical activity as much as possible, as much as the patient can tolerate. And we also do have resources where we can refer the patient to cardiac rehab. This graphic is from the American Heart Association, and something like this is also very helpful when we talk to our patients about non-pharmacological management of heart failure. And, everybody knows red, yellow, green lights, so it's easy to understand. So for anything that's in green, great. Continue doing what you're doing. Your weight is stable. There is no swelling of the feet and legs, no shortness of breath. Physical activity is normal. You're taking your medications as directed. You have lowered your sodium in your diet. You're attending your follow-up visits as scheduled. Keep up the good work. Doing excellent. The area in yellow, pay attention, use caution. Any symptoms that the patient might experience in this area, we let them know that you should probably contact your doctor, and or there may be a need for a change in your medications if you are doing everything on your end as far as, the lifestyle changes, etc. So worsening shortness of breath with activity, increased swelling of the legs, feet, and ankles, sudden weight gain of more than 2 to 3 pounds in a 24-hour period, or for 5 pounds in a week, trouble sleeping. These are signs that the doctor should be contacted. Any symptomatology in the red area, this is urgent, and the patient is advised that they need to be evaluated right away. They should call their physician and 911 or present to an emergency room. And symptoms in this area include shortness of breath at rest, increased discomfort or swelling in the lower body. Again, the sudden weight gain, increased trouble with sleeping, unable to lie flat, etc. You'd be surprised at the amount of patients that come in and say, they were up to like 3 or 4 pillows. So again, something like this is very nice for the patient to be able to understand the urgency or lack of getting to a provider. So as far as the transition of care pharmacists, again, we provide patient education, ensure that the patient is receiving the appropriate medications. We have completed all of our barrier assessments, and according to the heart failure guidelines, patients with heart failure should be followed up in a disease state management clinic. And this is when we make sure that our patients are scheduled for some type of follow-up. And I will hand over the next segment to Dr. Kohler. Thank you.
Thank you very much. So our patient has made it home. I already introduced myself, by the way. My name's Lisa. If you joined a few minutes late, I started at the beginning. I'm a coordinator at Memorial Regional in the cardiology space. I work in the inpatient and also assist with outpatient. So our patient in this case has made it home. They're in the ambulatory or outpatient space. And pharmacy plays a lot of roles that are different but similar and in new capacities once a patient gets to this setting. To name a few things that are highlighted in the literature, as well as leveraging some experience from our own institution, the ambulatory care pharmacists play a major role in educating patients and re-educating and re-educating. It's really important that patients understand their disease state, heart failure as a whole, and how to manage that, as well as all the medications that are needed to manage the disease state. In the ambulatory space, we're always assessing for barriers at each encounter with the patient, whether that's an encounter with them at the outpatient pharmacy counter, or if it's interviewing the patient in a clinic setting. Assessing for new medication issues is also something that we do often, especially because patients get new insurance. So medications that used to be covered, are no longer covered, or preferred agents have changed because insurances have changed. So we're often assisting in non-clinical interventions too, like setting up home delivery when patients have transportation issues. Literature does support pharmacist managed GDMT clinics in the heart failure space. And even if there aren't resources to have a dedicated pharmacist in that setting, any optimization that can be done of these patients based on everything you've already seen in this presentation from the guidelines shows you that we get closer to improving their outcomes. So when heart failure disease management clinics are in something that the patient has access to and a pharmacist involved in that clinic setting, it does allow for the patients to have office visits after their hospital encounters, and that allows the pharmacist in that space to reinforce the inpatient education that has occurred, as well as help optimize the medications on the outpatient space. So I encountered our patient MT when they arrived for their heart failure clinic appointment about 2 weeks after their discharge. The patient reported taking the following medications that you see here. So the post-hospital office visit, which is what our institution calls these appointments after they have an inpatient setting, an inpatient encounter, they include the patient meeting with the physician or an advanced nurse practitioner that's on the heart failure team. They'll meet with the patient to review imaging results and discuss any potential follow-up procedures that might be needed, such as blood work. Before the patient sees the prescriber, they often meet with the pharmacist first. And this gives the patient an opportunity to talk about their medications that they're taking, and the pharmacist can review it for accuracy and make sure nothing has changed. There were no barriers that occurred between the time that they were discharged and the time that they're coming for their appointment. It allows us to assess those financials. It also allows us to maybe check eForce and other third-party available databases to see the patient's adherence and compliance. It doesn't necessarily have to be with these medications. A lot of times patients can show how adherent they are and how compliant they are from previous disease states and previous refill information. So our patient's benefit investigation that was completed during the inpatient stay had actually resulted. So when the patient came to their outpatient visit, we were able to let them know that the prior auth was approved and the insurance company was going to have a 30-day cost was going to be $15 copay for the month. At these types of visits, another possibility for meeting with the patient is to talk to them about their disease state management as a whole. They can have one-on-one appointments with prescribers. They have one-on-one appointments with pharmacists, and it really allows us to elaborate on any symptoms that the patient's been experiencing and really manage the side effects for the patient. So one thing about heart failure management clinics is that if a patient is unable to be seen in person due to distance from the clinic or mobility issues, when those come into play, remote monitoring becomes something that is really valuable. Heart failure patient management in terms of remote monitoring could probably be an hour lecture all on its own. But for the purposes of our discussion here, essentially it helps the patient monitor. They get devices at home like scales and blood pressure cuffs and thermometers and things like that. And these devices are connected to the internet. And so it allows the information to be relayed in real time or at set intervals to computer systems that the clinic has access to. So the practitioners will review the data and they can make adjustments to the patient's therapy to try to prevent the patient from having emergency room touch points, whether it's an observation stay or a full-on inpatient admission. There are lots of different advanced monitoring devices in this space. Like I said, we could talk about it for a long time, but one of my favorites is a vest-like device that's worn, and then the patient lays down on a pillow-like device, if you will. And after just a few minutes, you can actually assess the patient's lungs for any signs of fluid buildup long before the patient ever even experiences shortness of breath or expresses that they're having shortness of breath. This type of remote monitoring would then also allow for abrupt changes too in vital signs that can be addressed sooner than waiting for the patient to have an exacerbation and then make it to the emergency room. So back to our patients, one of the roles that I mentioned was optimizing GDMT. So the guidelines do give us some target doses that we should try to aim for regarding several of the pillar medications, and particularly these medications that our patient was on. So our patient's vitals remained mostly stable, and it seemed like their blood pressure had been tolerating the switch from the lisinopril to the Entresto. And so an increase in Entresto dose was warranted. The metoprolol and the spironolactone, the patient is also a candidate for uptitration. It might not be wise to uptitrate all three or make adjustments to all three at the same time. And so the recommendation is going to be to wait on the blood work that they just got a prescription for and see about the potassium before making any adjustments for like the spironolactone. So I'm going to talk a little bit about trial data for just a second, because I think it highlights some really important initiatives that pharmacists can play a big role in the outpatient setting for heart failure patients. There was some data that looked at GDMT and patients that had HFrEF and what how close they were to being on target doses. And so you can see for the ACE, ARBs, and ARNIs, about 50 to 60% of the patients were on less than 50% of that target. Only a small percentage of patients were actually in blue at target doses. And the same story reads for beta blockers as well. Almost 50% of the patients are on less than half of these doses that we know the guidelines show have such great benefit for the patient. Of course, as pharmacists, our mind goes to, well, maybe it's because of side effects, or maybe they were intolerant, or there were mitigation strategies that were implemented. And when you look at the additional data surrounding this I thought was also really compelling. So patients that are intolerant to GDMT were reviewed and sort of stratified as to what was the reason for their intolerance. And the study classified the ACEs and ARBs and the beta blockers at patients at suboptimal doses. Those are the top two graphs. And then the bottom two graphs are non-prescribing of ARNIs and MRAs in these bottom two images. So what you see really on all four of them is a large section of yellow in these pies. So while hyperkalemia, hypotension, bradycardia, fatigue, and even renal impairment are all made the cut here for why patients were intolerant to GDMT, which is what we would all expect, more than half of the patients really didn't have a reason to preclude them from being on the therapy or on higher doses of the therapy. So those patients are really good targets for pharmacists to assist in getting these patients initiated on GDMT therapy. So our patient didn't experience any barriers at the time that they came to their post-hospital office visit, but some concerns that we run into quite often do include some of the things I just mentioned. So acute kidney injury, hyperkalemia, hypotension, adherence and cost also play a pretty large role. Mitigating these barriers to improve adherence really does lead to better outcomes for the patient. So if our patient had experienced renal function and that was an issue upon this visit, some strategies could be holding the ARNI or reducing the Lasix maybe to once a day, depending on their volume status and some other parameters. If the patient was hypotensive, we could take the metoprolol dose down a little to 25 milligrams and then up titrate a little bit more slowly. If the patient can't manipulate prescription bottles because of dexterity issues or strength issues in their hands, we can always assist patients by maybe instructing them or setting up pill boxes for them. So you sort of get the idea of what I'm saying here is that with each barrier that we identify in the ambulatory space, we find a way to mitigate that so that we can try to maximize patients and titrate their doses to the maximally tolerated dose. And ideally, that maximum tolerated dose is the target dose for that agent that we're looking for. So our patient did have a successful post-hospital office visit. They had their prescription in hand to go get labs as a follow-up for their next visit. The ambulatory care pharmacist worked with the outpatient heart failure team, and we continued to minimize those GDMT barriers and ensuring that optimal dosing was achieved. The patient also received additional counseling at this visit about side effects and medications that they were taking. Our patient was set up for regular visits to be seen in the outpatient clinic for continuous follow-up monitoring to make sure that we assess the patient on an ongoing basis. The patient did report making appropriate lifestyle modifications that were recommended. They're trying to reduce their risk of future exacerbations because they don't want to end up where we started, which is in the emergency department. So here are some of our additional references that we use to put this presentation together. And now we're going to get some assessment questions. So if everybody has a few moments, assessment question number 1, if you can put your answer in the chat. GDMT for heart failure. It includes all of the following except. I see a lot of people putting D, and sure enough, it is calcium channel blockers. Good job. All right, I'm going to go on to the next one. So assessment question 2, which of the following are barriers to GDMT optimization? I see a lot of letters of E coming through, and that's right. We mentioned a lot of these throughout the presentation. During the inpatient stay, we're assessing for these things as causes for admission. We're assessing them when we initiate agents in the hospital, and then we're assessing them when the patient's on these agents in the outpatient setting. And then the last assessment question, true or false? Non-pharmacological counseling is an integral part of education for heart failure patients. I love it. Yes. So the answer is true. It is very important that we counsel these patients on disease state as well as on their medication regimens. So thank you so much for attending and joining our journey with this patient for their heart failure from the emergency room all the way through the ambulatory care space. If anybody has any questions, now would be a great time to ask. And I'm just going to put on the next slide so everyone has some information about how to capture their CE credit for attending this discussion today. Does anybody have any questions that we're able to address at this time?
I had several direct messages about the handout, so if I could just get a copy of the PDF, I can send that out to the attendees.
Sure, that's no problem.
Thank you.
Mhm.
Hey, Lisa, do you have any suggestions for how to justify a technician position in order to help with the evaluation of the cost of medications, maybe for systems that don't have that position in place yet?
Yeah, it's really kind of understanding the process of the disease state starts to help you understand how a technician could play a really helpful role here. I think that the more the guidelines are expanding and accepting of some of these new agents, you wind up getting these cost issues and these barriers to accessing these therapies. What we have tried to do here, we don't have a technician specifically in this role. It is something that we're also trying to put into place. It's mainly showing this patient population. When leadership understands that this patient population is a little different than some of the other populations we see in the hospital, you kind of have to look at that as a new lens. This isn't a patient that we're only going to see on this admission once or twice. We're going to see them when they come here. If we don't have a clinic, we're going to see them when they come back with an exacerbation. And so sort of showing that there is a way here for us to keep the patients out of the hospital, and this is a good use of our resources. That's the strategy that we've been trying to follow.
Lisa, I'd like to add to that also by saying that if you are able to collect any data, maybe on your readmissions or patients who are reporting that they, abandoned prescriptions, etc., that's also good data to show to, justify the need for this type of position.
Yeah.
Thank you. There's a couple. Thank you. Sorry. There's a couple questions in the chat.
Yep.
One of them is, please share your experience with Furoscix used to avoid readmission.
So Furoscix isn't our go-to to avoid readmissions. A lot of times patients that are on Furoscix have already been on oral and have needed to have several exacerbations where they came to the hospital with overload. So we find that the patients that do really well on a drip in the hospital, and then we convert them to pushes and we sort of see their output not be as robust as we would like, Furoscix does become an option on the table. If you can get patients to have their fluid status somewhat under control, we know that that's not going to cure their heart failure in any way, but it certainly facilitates their body and not having to go down the road of compensating because it's having to handle all of that fluid all the time. And that's the one benefit of the Furoscix. They're getting constant diuresis, low and slow, to sort of prevent that buildup that keeps a patient in the hospital or keeps them coming back to the hospital.
Thank you. The next question is, I know we're short on time, is there an update to Medicare coverage of Entresto?
Is there coverage where?
An update on the Medicare coverage of Entresto.
I don't have an update yet. We are patiently waiting.
Okay, thank you. Do you have a workflow in place to address when patients reach the coverage gap, or any resources aside for patients' assistance programs?
I wouldn't say that there is a workflow per se. We do, sometimes get patients who have reached the coverage gap, who are in the donut hole. In that case, our medication access specialist will see if there are any, patient assistance. Well, I see you have here aside from patient assistance programs, see if there's, any type of foundation grants available, et cetera. And as I said during my portion of the presentation, there are times when we just have to go back to the prescriber and say that we have exhausted all avenues, and is there an alternative that can, be prescribed?
Thank you for that.
I know we're short on time. There was one other question I just wanted to address about urine output and what was considered an appropriate response when we were doing that bolus challenge. So
Mhm.
500 mLs in about a 4-hour period is about what we look to see if the patient has had a positive response or not.
Thank you. There was one just above that question about compensation. I'm not sure that we have information about how these services are compensated.
We're working on that piece of it. This is a really large, robust program that's growing, and that is actually the phase that we're coming up to next on how to monetize some of the great services that we're doing to help the patients.
Thank you. Dr. Zilbin shared some information in the chat. There is a heart failure foundation that patients can apply to, and they can receive upwards of $10,000 annually for assistance with medications. And that brings us to the end, unless there's any other questions. Thank you so much on behalf of the Critical Care Emergency Medicine Clinical Forum, FSHP. Thank you again to our speakers. I hope you enjoyed. We'll see you soon.